A very good afternoon, Dr. Chairman, and to everyone gathered here today. I guess my talk time is now slightly less after all that introduction. This is going to be a rather scientific talk, and that's why appropriately it's on the medical track. Has immune therapy come of age? I was initially asked to talk about cell-based immunotherapy for the palliation of cancers rather than as a mainstream treatment. So, a final answer to that question that was posed to me, has it come of age? Then the answer is yes. FDA just recently approved immune cell therapy. This year, 3 months ago, they approved it for TIL, that is tumor infiltrating lymphocytes. Now, if you look at that, I'm going to beam all the way there. If you look at that, it's a very tedious process. I get the tumor from the patient, isolate the tumor infiltrating lymphocytes from within the tumor, grow that, isolate that again, grow that multiple times, and then inject it back. And this treatment was approved for advanced melanoma in patients who have failed all other medical therapies. So yes, FDA has started with the first TIL approval. And as you know, in fact, there's been a lot of other cellular immunotherapies that has been approved. CAR T, for example, which we are not going to go through here, but that's a big field in hematology. So what is the rationale for the FDA approving cell immune therapy at the beginning of this year? Well, the rationale is this, and I'm going to go through that, being mindful that I'm not an oncologist and all the experts are sitting in front of me. But what I do know is this. Chemotherapy is the basis for cancer treatments. Chemotherapy depletes the white cells. And when the white cells become depleted in chemotherapy, it takes ages for the white cells to be restored back to normal again. And during this critical period, the first 2 weeks up to 9 months, the chance of relapse, the risk of relapse is much higher because of the depletion of the immune system. What could we do? G-CSF, of course. But G-CSF mainly takes care of neutropenia. So it helps to prevent sepsis, which is one of the major causes of complications of chemotherapy. But it doesn't do as well to increase or improve lymphopenia. And as we know, lymphopenia is associated with a worse prognosis, a worse outcome generally in all solid cancers. This meta-analysis looks at lymphopenia where they compared lower or higher above this line. But as you can see from this line, this is not very severe lymphopenia. The clinical oncologists, you'll see much worse lymphopenia occurring, not lymphocytes at 20%. It's lymphocytes at 10, even less than 10%. So the prognosis is a lot worse in the real world. And then there is that part where if we are lymphopenic post-chemotherapy, or we are just lymphopenic post-radiation, or lymphopenic because of the prolonged chronic cancer state, lymphopenia itself is an important criteria to determine the efficacy or the effectiveness of targeted therapy. Targeted therapy actually relies on activating the T cells to fight the cancer. If we didn't have enough T cells, activating whatever left in the body may not be enough to actually fight the metastatic cancer. Immunotherapy itself also depletes cancer, also depletes lymphopenia. So it is quite important whether it is a patient post-chemotherapy or whether it is a patient that we are planning to go for targeted therapy, to also look at the lymphocyte level of these patients. Immunotherapy itself actually depletes the lymphocytes. Again, that's something that is shown. Within 6 months, about 40% of patients will become lymphopenic. Now, why did that happen? Now, that's not the same concept as chemotherapy. Chemotherapy kills the lymphocytes. Immunotherapy activates the lymphocytes and get them to work. So all these lymphocytes have now rushed into the tumor infiltrating lymphocytes. They've rushed into the tumor. And then what? Once they rush into the tumor, they can't come out, they can't grow, they can't sustain. And then again, you are left with a depleted lymphopenic state. It's not sustainable. So what worked up to 6 months became less efficacious at 12 months and then may become resistant at 18 months. Then the word may not be resistance. The word may just be the lymphopenia, reducing the efficacy. So, given all of that, one of the things that we want to do is perhaps to be able to shore up the lymphocytes in these patients. When we say lymphocytes, we say lymphopenia. But lymphocytes is divided into B cells and T cells. And well, actually, we really just want the T cells. And in fact, actually, we just want the CD8, the cytotoxic T cells, T lymphocytes, and not really the CD4s. There's a lot of buzzword out there in the market today that talks about NK cells. So you know more about NK cells than anything else. That, unfortunately, is a marketing hype. I believe so. What's the difference? Well, the difference is NK cells is on the innate side, rapid, and the T cells is on the slow response side, slow. What we really, really want is something that sits right in the middle, that shares characteristics of both. So yeah, there it is. And so we call that, scientists among us, very novel name, NKT cells. NK and T. So what's the difference? T cells, they act very slowly. They're very disciplined, but they act slowly. They will act for a long time. They can last for 1 to 2 years. In the inactivated state, they can last for 7 years, but they act slowly. And they act via MHC molecule as antigen presentation. Without antigen presentation, the T cell is just going to sit there and let the cancer go past them. NK cell, on the other hand, is very, very fast, very aggressive. You know, put them in and they start fighting everybody. But they don't last for very long. They survive for 2 to 4 weeks. That's your platelets, 2 to 4 weeks. So what would the cancer cell do if they've met with NK cell? They would just sit by, hide, and wait for 2 to 4 weeks until the NK cells die. So again, what we really want is NKT. What NKT really does is not just it shares the characteristics of NK cells and the T cells, but that we think that it works very, very exclusively on tumor cells. It responds, it reacts, it looks for cells that carry a particular marker called NKG2DL. I think I got that wrong. But what it is that marker is exclusively expressed or even overexpressed on tumor cells only, and hardly on healthy tissues, never on hematopoietic stem cells. And hence, you have a cell that homes in on tumor cells and doesn't cause GVHD, doesn't cause cytokine release syndrome that you would get with CAR-T. So the question is, what should I use? What should we use? NKT, CTL, NK? My answer is, why are we limited to one? Why not choose all four? They are all in our body anyway. We're taking blood from the patient. Why are we choosing like what US FDA just approved, one, TIL? And if you're going to bring the army in, then why not bring the elite of the army, and not just the T cells or the NK cells, but the really, really good army trained to fight, trained to recognize only the bad guys. And so that's where we are. NKT is actually part of CIK. I'm trying to get you into this concept. CIK stands for cytokine-induced killer cells. There are 3 fractions: T cells, NKT cells, and NK cells. Well, very little of the NK cells, more of the T cells and the NKT cells. And the central coordinator that provides for this orchestrated attack is the one that sits in the middle, the blue one, the NKT. It works directly on the tumor without antigen presentation. It influences the NK to do the same, and it helps to pick up the antigen from the dendritic cell and present that to the T cell as well. An NKT cell is actually quite easy to make. It's autologous. It comes from the patient's own blood. That's where it should come from anyway. And in the process of culturing it, just using IKT2 and anti-CD3 antibodies and IL-2, we can grow it very, very rapidly. Within 2-3 weeks, we can multiply it very, very rapidly. And in that process, we can change the majority of our NKT cells and T cells to all express the NKG2DL receptor to recognize and specifically target tumor cells. It's fast, it's quick. Of course, it's safe and sterile when it's done in a GMP facility. And it's returned to the patient as a homologous use. So this is not stem cells. Stem cells is when you take it from the bone marrow as a stem cell, and then you put it somewhere else and pretend that it's going to do something else at another organ. No, this is taking white cells from the bloodstream, putting it back into the bloodstream, and to do this original intended action, which is to act as an immune defense system. And even we are talking about patients with lymphopenic states, post-radiation, post-chemotherapy, with severe metastatic cancer. We showed that we are able to, with the available, this is globally available technology, to culture it from about 1 million NKT cells to at least 5 billion NKT cells, and actually on average hitting about 8 billion NKT cells. As a context, I think we have about between 15 to 25 billion T cells in our body, on average, in a healthy person. Talking about half of that, T cells rather than B cells, then we have half of that, 8 to 12 billion. So providing something like 8 billion cells in a patient who's lymphopenic, with very, very zero, very low lymphopenic count, actually helps them to restore their immune system again. And it's not something that is being promoted only in Malaysia, but it's a trial that's been going on everywhere. And I think the important thing here is it's all being used as an adjunct therapy, as a rescue therapy, well, as a palliative therapy. And as a palliative therapy, it actually works very, very well, because in this case, we are not talking about disease-free survival. We're just talking about progression-free survival, overall survival, PFS, OS. And I think on that basis, CIK actually has a role to play. Again, adjunct therapy, palliative, post-chemo and all that. And the cells we use, I mentioned this, NK is a hype. People are using it as a preventive treatment. Prophylaxis is never proven, not proven, okay? What did we get approval for is actually for CIK, 3 cells rather than 1. A little bit of blood. NK cells could not grow. So when people use NK cells, they have to take about 300 to 500 mils. So that's a healthy patient. And then they will freeze it because it can't last very long. But freezing it actually reduces the efficacy. So we go with 80 mils of blood, and then we culture it over 3 weeks, and then we infuse that back. And it really, really works together with immunotherapy. If I have a chance to show you the testimonial of one patient. What did we do in order to justify to the MPRA that we have a very solid, credible product here? Well, we started with proof of concept mechanism of action. We took our CIK cells and we co-cultured it with breast cancer cells, lung cancer cells, and colorectal cancer cells. And it reduced it in a very dose-dependent manner. The 2 different lines you see at every dosage is a comparison of healthy cells and the cancer patient cells. And it works just the same. And I think this was actually done in Utah. Dr. Tan Yuan Fen is sitting up there. Thank you very much for doing this, you and your team. We went further, and this is done in Utah as well, I think. We took the cells and we did a proteomic analysis from the culture, the co-culture of the cancer and the white cells, where we saw the cancer cells were being destroyed. We did a co-culture. And when we look at the co-culture, we saw there was a massive reduction, a significant reduction in, there you go, a significant reduction in all the pro-cancerous cytokines, an increase in the anti-cancerous cytokines, and the anti-metastatic cytokines as well. Next, we then injected colorectal cancer cells into white rats and mice. And then here we have 3, 4, 5 charts. Blue, cancer alone, HCT plus low dose of CIK, high dose of CIK with 5-FU chemotherapy, and a combination. And I think you could see very clearly that it is the one that is combined that does the best. Actually, chemotherapy sits between the low dose and the high dose. What I didn't show you is that a lot of the animals that received chemotherapy suffered, and a couple of those animals actually died. We measured the tumor growth and the growth inhibition, and in all cases, it improved. There was a big improvement in that. So because of that, and I want to let you know that a new regulatory framework in the registration of cell and gene therapy products was announced in 2016 and implemented and enforced in 2021. And in order to justify the continuation of such novel cell and gene therapy products to remain in the market without enforcement action being taken, as written in a letter like that, we have to prove all this. And we have to keep proving subsequent stages to justify the continuation of the products in the market. It's not a full approval, it's just a kelonggaran, allowed to remain in the market while you get all your act together for the full registration. It's not product approval. But it allows us, and MPRA allows us to then continue to collect clinical data. And this is my last 2 slides. So we did. We collected more data as much as we could. And this is a patient, one patient I want to show you, who had completed chemotherapy in 2021, but relapsed in 2022. They detected EGFR exon 19 deletion, and they started her on osimertinib. It seemed to have stabilized the disease initially, but by November 2022, it had progressed, and the doctor deemed her to have failed the therapy. She was planning to start palliative chemotherapy, and of course, she then came back to Malaysia and wanted to say all her farewells and all that. And while here, her palliative doctor referred her to us. So, with all the consent and everything taken, this is not paid. This is part of a compassionate treatment, it's not paid. We did 3 AMIT infusions. She did a scan in January before and in April after that. And these are the scans before, and this is the same patient after. Now, this is a patient who had done chemotherapy 2 years before. She had failed immunotherapy. The doctor has planned to start chemotherapy palliatively, but has not started. And the only thing she did in these last 3 months in between was the white cells. Was it the white cells alone that worked? The answer is no. I think all of you know that targeted therapy that you started remains in the body. Those white cells, that targeted therapy was effective. It didn't fail. It did activate her T cells, but there weren't enough of it. What did I do? We grew those T cells. We cultured and we multiplied those T cells, and then we put it back in the body. Now she has enough T cells that have been previously activated by the osimertinib. That's what it worked. So this is my last slide, last 1 minute. Just to summarize, without my glasses. Chronic cancers and its treatments do deplete the white cell count. Neutrophils are generally supported by GCSF, but not lymphocytes. But a low lymphocyte count causes a higher risk of relapse and actually makes it more difficult for us to initiate or maintain targeted therapies. With CIK, we could shore up the proper relevant cells. CIK, instead of just a single NK cell alone. It works specifically on cancer, without causing GVHD or cytokine release syndrome. We have shown it in both our laboratory and animal studies to be effective. We have received conditional allowance, golongaran. I can't even say the word in English, what golongaran means. But that means that we are allowed to carry it out while waiting for full registration to take place, which is taking its time. And has immune therapy come of age, at least as a palliative therapy? 3 months ago, US FDA has just approved the first cell immune therapy. Thank you very much for your attention.
Prof. Chin, for the enlightening session. Yeah, so we open the floor for Q&A. He's a very remarkable speaker, and yeah, I'm sure there are a lot of burning.
Oh, no.
It's just a simple one. You said you did 3 sessions for that patient, right? It was under compassionate use. For example, if say it is for non-compassionate use, how much does it cost roughly?
Well, actually, we don't use it for non-compassionate.
So you say if I have a patient who has failed multiple lines of treatment and I want to send to you, how much do I tell the patient that she needs to fork out?
So to be honest, I think the cost of culturing all of this would, at the moment, it costs roughly around 20,000 ringgit per session. That is not really taking into account the running cost of the GMP lab, and not taking into account, of course, if we are going to complete all the clinical trials, so on and so forth, I think the cost may go up after that. But the cost itself, just the cost, at the moment is 20,000 ringgit, more or less.
Thank you for the fantastic talk. Very enlightening. Do you have patients who have undergone the therapy alongside the treatment from the oncologist, like they are on immunotherapy as well as undergoing this therapy or targeted therapy? And is there any added toxicity that we should be aware of? Thanks.
Right. Actually, we are normally referred to patients, not really by the oncologist, but by the palliative doctors. So these are people who generally would have tried and failed at least 2-3 times of chemotherapy or targeted therapy. Doing concurrently, that's something we want to do, but that's all in clinical trial stage at the moment. Yeah.
Thank you.
Thank you, Dr. Malvinder and Dr. Jennifer. Any other questions from the floor?
Hi, Doctor. Thank you. Just want to ask, what's your opinion on this spike protein from COVID-19 on this lymphopenia so far? Have you seen any cases of effect of spike protein after COVID, or maybe certain treatments,
Okay, so no, we didn't really look into spike proteins, especially after COVID. As you can see from the MPRA ruling, the actual framework or the regulation started from 2016. So we had 1 year before 2021 the enforcement. So between 2020, that's in the heart of COVID, to 2022 July, we actually collected the data for some 48 patients. All of them at stage 4, all of them have failed other therapies. Of course, we didn't look so deep into that, but what we did was we looked at just the overall survival. At the moment, I have to say that we are achieving some 80% 3-year survival. Yeah. Not progression-free, they are progressing. Yeah.
Thank you, Doctor. Dr. Hadi?
I'm Dr. Hadi from Qatar Cancer Society. In Qatar now, we are, thank you for presentation. Now in Qatar, we're really investing in precision medicine and immunotherapy, and actually the whole concept of precision medicine and immunotherapy, it turned into investment case for the country economy. And we have if you guys had the chance to visit the gene immunotherapy centers in Qatar, it's like candy shop. Whenever they go, the kids when they go to the toy store, oh my God! So there is a lot of investment in the. But my question, my question is more from the equity and the patient perspective. So you mentioned that this is for compassionate use, and I admire your, the center is actually investing in this high costly, and I understand the cost come behind this because as Qatar Cancer Society also we support all the new innovation targeted therapy. So we have some patients support them with a $500,000 Qatari riyal, which is almost less a little bit than $500,000 ringgit. It's the same. Are all the patients that they are eligible for this compassionate use aware of this? How do you disseminate the awareness of, because one of the things in accessibility clinical trial and compassionate use, you only maybe a small network of oncology that you work, or palliative oncology that you work with, they are aware. But are you working with how to disseminate the awareness among that cohort of the patient? And the second question, and that's what we're facing in Qatar, and I don't know you from experience, the level so far, the patient, when they get into precision medicine or target therapy, their understanding is still not, I mean, they say, yeah, let's try it, but their full understanding of that treatment that they're going through, it's not the best. I mean, they don't have this full understanding. They're just going to it because it's a, it's some, I mean, I feel they're not 100% informed when they go into that decision. They just go to it because it's a option to save their life. What do you do for effort and for educating patients through going through this very highly advanced treatment methodology? Thank you so much.
Thank you.
Great work.
Yeah, so I do not know how much you all understood what I just said. So therefore, the patients understood a lot less. But I want to talk about the cost since you mentioned the cost. People talk about CAR T as a very, very precise medicine using CD19 that is found only on B-cell lymphoma. And the cost of producing the CAR T cells is about $500,000. It's impossible to get the kind of treatment available in Malaysia. And therefore, the manufacturers don't even bother to come to Malaysia. I'm sure you all know that. In contrast, we are talking about 3 sessions which cost 60,000 ringgit, roughly about $15,000. And again, even though we didn't talk about it as CAR T, this is still cells that express NK2GDL, and NK2GD ligand is actually exclusively overexpressed in most of solid cancer tissues. So this is as precise a medicine. It's not glorified because it's been around for so long. Hematologists have been using it just as an adjunct to shore up lymphopenia. We've never really looked at its efficacy beyond just what numbers are. So I think actually in terms of cost, and I'm sure the cost will actually go higher than 20,000 per time, but it's not going to reach $500,000 or 5 million riyad, And I think this is where maybe Malaysia has a very big role to play. We can do a lot more better things, global standards, at a much lower cost. Yeah.
Actually, that's one of the things that Qatar is now, the CAR T cell, we are, even in CAR T cell, so I mean, I agree with you. So even the manufacturer of CAR T cell, they look at Qatar as a small country. Why we need to invest to have a lab in CAR T cell in Qatar, and that's why we are looking. I mean, the oncologist, the team is looking into the option of looking into CAR T cells that in the region, and other treatment option that from our region instead of going all the way to get it from manufacturer North America and Western Europe, which is the cost is unbelievable.
Yeah.
But I admire it. This is something I think this is where the investment in Asia lay, that we need to invest in, and we need to one of the things that always kind of, I don't know your feeling about this. We had discussion. I'm part of the National Cancer Governance Board in Qatar. So we sit down discussion, we say, no, we cannot get this treatment because it's not FDA approved or EMA, whatever. And I tell them, sorry, I'm taking time, but that's something we need to overcome. I mean, our approval in this region, as robust and other places, we need to believe in our criteria and to overcome this curse of it's FDA approved or not FDA approved. We can have our own approval in the region and check the safety. Thank you. Sorry, took your other speaker time.
Thank you, Dr. Hadi. Thank you, Prof. Please
Thank
stay
you
on the
very
stage.
much.
So we are closing the Q&A due to time constraints.